think we will go ahead and get started today. Hello and welcome to everyone that's joining for today's webinar. Thank you for taking time. We're looking forward to another great session to talk about how we're using large data and to inform risk management and patient safety initiatives for medical groups and hospital systems. For today's webinar, we'll have two presenters. First up, we'll have Scott Richards. Scott's the co-founder and CEO of D2I. D2I specializes in healthcare data analytics and has been instrumental in the work that we're doing together with the Sullivan Group on our patient safety initiatives. Then we'll hear from Dr. Dan Sullivan. He's the founder and the CEO of the Sullivan Group. Sullivan Group specializes in clinical risk management and patient safety with a particular expertise in emergency medicine and avoiding diagnosis-related errors. We'll be discussing the risk dashboard, which is a new application that was co-developed by the Sullivan Group and D2I. And feel free throughout the session today to ask questions through the chat or the Q&A. We will answer those questions at the end and open up for discussion at the last 10, 15 minutes of the webinar today. But again, thank you so much for your time today. Scott Richards will start us off. Thank you, Scott.
Hi, well, thanks, Brent. Appreciate it. So good afternoon, everybody. Likewise, I appreciate you joining us. Our last session, there were quite a few people that were new to D2I and me. So we ran through a bit of a review of a little bit of background of what it is that you're going to see in a few minutes, as well as for those that weren't familiar with D2I, a little bit about D2I. So this may be for those of you familiar with D2I, a bit of a review, but it sets up really how we got from what D2I has been doing over the past 10 years when we set out with a mission really to provide emergency medicine and hospital medicine stakeholders with performance analytics and dashboards that were needed to better understand their clinical, operational, and financial performance and identify where quality and process improvement efforts may be best focused. And we did this and do this by making sure clients have the timely information that they need and trust in order for those productive conversations that change requires to be able to take place. And in that 10 years, a lot's transpired since we set out with that mission, not only for us as a company, but also for the emergency and hospital medicine specialties that we serve. So much of what we do and offer today versus 10 years ago can be really directly attributed to working closely with our clients and paying attention to the market and finding partners like the Sullivan Group out there who we can collaborate with to bring to bear better solutions and capabilities into the space. The slide that you're looking at here sort of gives you a sense of our progression over the past 10 years. And while our original mission still remains central to what we do today, it's been evolving. So the foundational element, just about anything you do in this space, is data. It's what we need in order to do what we've been doing. Thank you, Brent. And it's what is necessary in order to do what you're going to see in a few minutes. We acquire and integrate and normalize and curate data from multiple source systems in the healthcare environment. We get data from revenue cycle management systems, from clinician schedule and hour systems, patient satisfaction services. And for many of you, I'm sure you'll appreciate and agree that the most challenging source system is the electronic health record, or the EHR. Today, D2I acquires EHR data for more than 300 hospitals and spans somewhere in the neighborhood of 60 to 65 health systems around the U.S. And with all those hospitals and over the time that we've been in business, we have over 45 million unique patient encounters in our data warehouse. And we're ingesting somewhere in the neighborhood between 30 and 35,000 new patient visits every day. So this is all building the background and backdrop behind having the data necessary to do kind of things that we're doing here with the Sullivan Group. So the thing that makes us also unique is we're vendor agnostic. So the risk dashboard you're going to see in a few minutes is vendor agnostic as well, meaning it can sit on top of any EHR that you have or your practices have. And we acquire a level of detailed transaction data that include both structured and unstructured data. And it's really the unstructured data that we're really looking to exploit over the next year or two. And what really gets us excited about having access to that data to do the things that we're doing. This is the data that we acquire today allows us to do what we do today. The data that we acquire today positions us not only to serve up the information and data necessary for the risk dashboard, but to support our evolving mission to go further into the space and solve problems. And it's also the data that got Dan and his team excited about what was possible through collaboration. Next slide, Brandon. So we believe the risk dashboard reflects the kind of collaboration that is going to be necessary, bringing together disparate organizations with very specific, varied and collective domain expertise like the Sullivan Group and D2I teams brought together, and bring it together with passion. So anecdotally, that's really what happened with where we got with this risk dashboard. Tactically and technically, simply put, it's a data-driven product. That's the result of applying the Sullivan Group's patient safety and risk mitigation best practice algorithms that they've spent the last 25 years developing with their clients, and D2I's data that we acquire. You're going to see that in a minute again when Dan is sharing it with you. What it represents for D2I is we're continually seeking, as I mentioned, to collaborate with domain experts in our space, like the Sullivan Group, and go after the evolving mission to continually provide services and solutions that support our clients and the specialty we serve. It's also another demonstration of D2I's ability to leverage the data acquisition and infrastructure that we have and expanding our scope and capabilities. So it's our hope that the risk dashboard provides emergency medicine specialty and its hospital partners a first of a kind opportunity to have the transparency that's going to be needed to identify and target for improvement the practice variabilities that contribute to medical errors and increased risk. So I want to finish up with 2 points. First, I expect most of you on this webinar appreciate Dan and the Sullivan Group's credentials in the patient safety and risk management. And it's really against that backdrop I want to share a comment that Dan made to kick off one of our first beta site product reviews. That really got my attention and leveled up my excitement for what's going to be possible through this risk dashboard, not just what you're going to see today, but as we evolve it as well. And I'm going to paraphrase here. He said this to the group that was looking at it, this is the first time anyone is seeing this kind of patient safety data. So it's really why we believe it represents a true inflection point for patient safety and risk management. The second point I want to make is I'm sure as Dan's going through this like us, you're going to be coming up with ideas for where the product like this could and should go. So while we're going to be sharing a product roadmap a little bit later, we are very interested in getting your feedback and hope you take some time to share it with us. So I'd like to finish just one additional thought, and that is when inflection points arise, they are moved forward because of vision and purpose and through collaboration. And it's the collaboration with the Sullivan Group that got us to this point. And we hope you join us in this journey because it's one that we believe can have a huge impact on patient safety and risk management. And so with that, I'm going to turn it over to Dan Sullivan to take you through the risk dashboard. Dan?
Thanks, Scott. That was really good, Scott. Really good. Nice to hear that introduction and the way you framed that. Hey, everybody. Great to be with you today. Excited to demonstrate to you what's come out of this partnership with the D2I. I'll tell you that we've been working on this for a little bit over a year. Met D2I some years back. Just the name D2I is, I think, brilliant. Data to intelligence. The way they frame the data makes it actionable and kind of drew us into this partnership. And it's been I have to say, in the 30 years we've been in business, of all the folks that we have worked with, this has really been a great development process with a great team of folks. If you don't know the D2I folks already, I hope you do get to know them. Also, before I get going, I'd like to say thanks for joining us. We're so happy that you could be here. I've looked at the list of folks who are attending, and for a good number of you, we've worked together, we've been partners, we've been clients, we are friends, and so thanks for joining us. We're always thankful that people are along to listen to the message. So I'll just a little bit of background about the Sullivan Group and myself. I'm a board certified emergency physician. I have a legal background as well. I ran a group in the Midwest, 20 emergency departments. I started at Cook County Hospital in Chicago, and then developed a group with our first graduating class and have had a wonderful practice of emergency medicine, a great emergency medicine career. But from very early in my days at Cook County Hospital, it was clear to me that there were a lot of medical errors. Before this became a big national phenomenon, the recognition of the number of medical errors, it was just happening all around me. And I thought we should do something about this. And so I've done a lot of lectures, wrote books, did tapes, did videos, did everything I could to kind of get the message out there in the 1990s, but realized that we really needed some kind of a scalable solution, an organized approach to make something good happen, and develop this mission with the Sullivan Group 25 years ago, improving patient safety by changing clinical practice, really changing behavior and reducing medical malpractice exposure. We've had a great run of it with a lot of hospitals and a lot of practitioners around the country. What it comes down to, big picture, a lot of things can go wrong, but in the world of medical error, number one by far is the delay or failure to make a diagnosis. And there are many things that we could look at. This just happens to be a particularly good article written a couple of years ago about the number of times that we miss certain things on the first visit. And the numbers are extraordinary. Spinal epidural abscess, we miss on the first visit 62% of the time. And it takes 3 or 4 visits to make that diagnosis. Acute aortic dissection, 28%. Pulmonary embolism, 20%. And so that's a big deal. It's a lot of medical errors. They don't all turn into malpractice cases, but they all hurt our patients, or many of them hurt our patients in one way or the other. So what do you do about it? Well, if you look at enough cases of spinal epidural abscess, you realize that folks are omitting analysis of, was there fever? Did the pain move from thoracic to lumbar? Was there a mechanism of injury or not? With pulmonary embolism, oftentimes it's the practitioner didn't know the patient drove from Las Vegas to Chicago a couple of days ago, never got that information. So there's things that we can work on. There's things that we can deal with. And so our approach over the years has been this cycle, this risk, safety, and quality cycle. And so, if I've known you for a long time, this is you saying, "Oh my God, Dan's doing it again." There's that cycle thing, but it really is absolutely critical. Folks need to know why we're missing spinal epidural abscess. They need to know why we're failing to diagnose pulmonary embolism. So you educate them because everybody needs to get on board. But we forget those things. And so we need a little cognitive suggestion or nudging strategy at the bedside real time while we're seeing our patients. And critically important is that we see data. If you're going to make gains and hold those gains, you've got to look at those issues behind back pain. You, the individual practitioner, you, the medical leader, you, the organization, you have got to know what that looks like if you're going to drive meaningful and sustainable change. So we've been doing that for years. We've got 750,000 cases that we have looked at in assessments. That was manual data extraction and very difficult. And we would do for our emergency departments that we work with, 25 chest pain cases and 25 back pain cases. And it's unbelievably difficult. It's not so different than these sophisticated, huge insurance companies that insure us. What are they doing? They're doing manual data abstraction. Um, and so what we're working on with D2I and what we've done is really transformational. And this is excuse me, part of an abstract that we've created for a presentation we're going to give the first quarter of next year. What you're about to see today, this is a groundbreaking shift in emergency medicine risk management. Because we are able through D2I to instantly mine large curated data sets and apply best practice algorithms to yield insights that we haven't had before. It gives practitioners and medical and hospital leadership an unprecedented opportunity to proactively decrease risk and enhance patient safety. Right? So that's a mouthful, but it's a big deal. And I haven't seen it before. What we've done has been very effective. We've dropped medical malpractice rates and medical error rates in the 25 years we've been doing this, and we know it's very meaningful for the clients and partners that we work with. But this is something different. If you know D2I, then you've seen this before. I'm going to do a slide presentation to demonstrate the risk dashboard for you. but this comes from this portal. And so username and password, and you're in. And the opportunities inside this portal are just about endless because you've got the data. You can do with it what you want. You can use the risk dashboards that we put up. You can download all the data to Excel spreadsheets, you name it. Very, very powerful. So I will start here, which makes sense. This is our first thing that you see inside the portal. It's key performance metrics, and this kind of a forest and trees discussion. This is looking at the forest, and you don't know what the trees are yet, so I'm not going to spend much time here at the moment. I'll come back to this at the end. But we pull out some important metrics in the current month. We're showing you September, for this is a real organization with four emergency departments and trends and rolling 3 months average. And you can sort of get a look and a sense of what's happening in those four emergency departments by looking at the trends. And we've got some issues to address here, but that's the forest, and we've got to look at a couple of the trees inside of this portal in order for this to make sense for you. So let's start here. Discharge of patients with abnormal or very abnormal vital signs. Now, this is just simply a critical issue in the practice of emergency medicine. And I have taught risk management for 3 hours at the ASAP Medical Directors Academy for 20 years. That's 40 times 150 per. That's about 6,000 medical leaders. Talk to them for 3 hours. And at the end, I say, I just told you a whole bunch of stuff. But if you take one thing from all these lectures that you've heard over this whole week, just take this back. Go home and fix vital signs. Fix the vital signs. Is it a problem? Yeah, it's a problem. Any analysis you do in the literature, I've got 4 articles here. You can find 40. But start with abnormal vital signs at discharge, dot, dot, dot. Increased likelihood of admission and death. Predictors of unexpected death after discharge. Cause more undesirable process outcomes. In particular, tachycardia, tachypnea, and fever more likely to return within 72 and get admitted. One study, 17% of pediatric patients are discharged with at least one abnormal vital sign with an increased relative risk for adverse events. Abnormal vital signs at discharge, a qualitative factor in patients who die shortly after discharge. Well, the problem here is you're not going to have evidence-based medicine where you've got a cohort where you evaluate abnormal vital signs and a cohort where you don't. If you got 100 patients with a pulse over 110, you're not going to take 50 and do nothing and 50 and do something. So just trust me, this is big. We do this case-by-case analysis of spinal epidural abscess and pulmonary embolism. Guess what the biggest red flag is? It's abnormal vital signs at discharge. Let's drill down into the portal, and this is just a phenomenal demonstration of my manual data abstraction of 50 charts versus here's September for this organization. Here's 12,000 discharges. Here's all the discharges, and over in the red square here is 10.3% of all of these patients went home with an abnormal vital sign. And you can see them all here. It's a pulse over 100 to 109, very abnormal over 110, 20 to 24 over 24. The most important, of course, is the very abnormal pulse. This is just way too many people going home, and with an abnormal pulse, and you can't say this isn't true. We validated this data; it's true, and these numbers are big. And if you look at the graphs below, you can see the numbers are coming down a little bit, but they're still pretty extraordinary. So what do you do with this? Well, you're in a portal. You just dial in ED1, ED2, ED3, ED4, and you can look at all 4. I'm not going to do that today because I will tell you that they all look like this. They've got part of the qualifying discharges because ED1 has got like 2,000, but the percentages all look the same. And they probably look the same in your emergency departments, and they look the same in my emergency departments before we did something about it. So now that when we talked to the practitioners about this, and one of the comments that they made, and this is kind of what drives how we improve and modify this program, is the physician said, well, maybe it's not us, maybe it's the nurses. Well, surprise, surprise. Are you surprised that we heard that? No, it's probably true in part. All right. So we use the portal and we can select, okay, who was, who had vitals and got discharged. And then who had vitals got discharged. And then there was another set of vitals, one's on the docs, one's on the nurses. Vital signs taken before doc decision to discharge. There were no other vitals. So the physician had that last opportunity to look at them. 6.5 of the 10.3 is the docs. And then how many cases after that discharge did the nurses take another vital sign? That's 3.8. Did they talk to the doc about it? They didn't talk about it. We don't know. But what do we got here? We've got data like we've never seen it before, in numbers like we've never seen it before, and we've got a major driver here to do something about it. Is it the doc's problem? Is it the nurse's problem? Is it the APP's problem? It's everybody's problem. This is a team issue. We will approach it in a team way. I am on in 1 hour with these folks to develop an implementation plan, and we want to see basically we want to see these numbers fall off a cliff, and we think that we can. Well, that kind of begs the question. This is all ages. Kind of begs the question. Well, what if it's a pediatric emergency department, or what if I just want to segregate out because adult vitals and pediatric vitals are real different. There's a number of emergency practitioners on this call who will not be able to tell me, nor can I tell you, what's a normal pulse and respiratory rate for a 2-year-old versus a 2-month-old versus an 8-year-old. They're very different. So let's take a look at that. Well, of the 11,000 patients, 9,700 were adult, 9.3 had an abnormal vital sign going home. In peds, it's 14.9. That's interesting. Maybe we need to do a little bit more focus on pediatrics and abnormal vital signs. We need to drill down to the practitioners. We need to identify which are the practitioners who are falling out. Well, there's a lot of high numbers there, and we haven't color coded them yet because what color should we make them? I mean, should we just make them all red? What's a normal number? I'd love for this to be under 2 for everybody because some people go home legitimately with an abnormal vital sign, but certainly not 11.6. 39 pulses over 110 for physician AAD here. ASQ's got 75, got double the patients, got double the pulses over 110 for adults. So this gives us an opportunity to get a look at, well, the opportunity, I think the biggest opportunity here is just share this at a department meeting or get this in an email, or show this at a virtual meeting, or get this out to everybody. Many emergency departments we've worked with over the many years start with de-identifiers under the physician list, and then they just identify them because it doesn't matter in time. No emergency practitioner wants to send home 75 pulses over 110. There might be a couple of albuterol treatments getting you up there. There may be some AFibs in there, but there's a lot of patients you don't want to send home. So they get this. They become proactive. They want to do something about it. They work with nurses. This really helps drive the team approach to all of this. And here's your top 20. And this has changed in the last 48 hours. Jonathan, who works with D2I, has now put percents on the left-hand side. This is great, and it just keeps getting better. And we talk to the group, and you look at this, and they say, yeah, we know. I mean, this makes sense to us. We know we've got great practitioners. We know we got middling practitioners. We know we got practitioners where we've got issues. This gives an opportunity, not with, if we do 50 patients, there's like 1 or 2 or 3 per practitioner. Here we've got every single case, and this will drive meaningful and sustainable change. But let's just go one step further, because who are these people going home with abnormal vital signs, and should we do something about it? Well, here's ED2. I'm the medical director for ED2. And I get this. Imagine today is November 4th. And when I get to work in the morning, I see this from November 3rd. And I see a 2-year-old with a pulse that is beyond 3 standard deviations above the mean. And I'm thinking, wow, that's too high. Now, this child had croup, maybe was treated with albuterol. Maybe I'll have an admin pull that chart for me, get a look, and maybe it's okay. I'm real concerned. I've got a 54-year-old with dental caries who went home with a pulse of 142. Now, maybe that person was in terrible pain, 142, and a follow-up vital sign would have been awesome, right? But 142 is not awesome. 142 is very concerning. Is this an abscess? Is it cavernous sinus thrombosis? We need to know. It gives you an opportunity to get back at as close to real time as we can today, and we want to get even closer. We want to be real time. But I was a medical director at many emergency departments, and the next day we pulled charts of concern. I'll tell you, these are charts of concern. I'm the medical director at ED3. I got a 63-year-old who's dizzy and giddy, and I got a pulse of 110. And that pulse was taken after the doc made the decision, which you can see here. Well, I'm concerned about a dizzy, giddy 63-year-old, and I probably want to follow up with that. The other one on here that really concerns me is I got a pain in the left lower leg in a 49-year-old. Now it's interesting, and this gives us an opportunity to study things like we've never looked at them before. Of all these people going home with a very abnormal pulse, which ones are okay? Well, we're seeing a lot of fractures in this group. It's probably okay, unless it's a compartment syndrome. But if this isn't a fracture, then what is that? A DVT and a pulmonary embolism, maybe? And we've got courses on this, and this one really concerns me. And this is a call we'd be making back. So we drill all the way down to the individual patient, and that's incredible. And we get this every day. If I'm a director, I'm on top of this every single day. And through education and through team training, we're expecting this starts to go away. And that's an amazing thing. All right, there's one tree. And here's another. The concept here is door to bed, door to greet, door to first vital sign. And you all have heard this before. You probably get these numbers and have been looking at them for years. And I'll suggest that in this ED you're looking at right here, that there may be chest pain out there, there may be abdominal pain out there, there may be testicular pain out there. And these are not things that need to be sitting around in a waiting room. So what we do, what do you do with that big number? Your door to greet is, 25. What do you do with that? Well, what we've done is we've taken a group of specific chief complaints where if you know emergency medicine, you know that every single one of these should get in right away because time is tissue. Abdominal pain over 40, maybe mesenteric ischemia, time is tissue. Chest pain, heart, time is tissue. Neonates with a fever, head injury less than 2, lost my vision, scrotal or testicular pain. Let's just look at a couple of these. 22 of the 4 emergency departments, they had 22 in quarter 3. They had 22 patients with testicular pain. 10 of them took over the 20 minutes to get in the door. You got 4 to 6 hours to get that person to the OR if it's a torsion. And I'm sure that many of you have got stroke programs going on, chest pain programs going on. You can't have 685 people in quarter 3 waiting for over 20 minutes to get into a bed with chest pain and get a thrombolytic in on time in the appropriate cases. I'm sure you get it. So the idea here is don't look at everybody. Look at the ones have got to get in. Create something around that. Um, do team training. We collectively, we're going to get this group of folks in. We're going to change these numbers. We're going to look at them next quarter. We're going to graph this out, and we're going to see what this looks like quarter over quarter. And we're going to try and drive these down. Just pick one and drive it down. Then 2, and ultimately this will kind of float out, to all of that door to bedtime, door to first greet time, and improve the entire situation. And again, you've got this is a portal. This is a slide, but actually it's out of a portal. And I'd like to know how does ED1 versus 2 versus 3 versus 4 look as this goes. And so there's ED number 1, there's 2. So we've got on that graph, we've got the green, we've got you up to 20 minutes there, and then we've got folks in the red if it's over 20 minutes, and there's a lot of red there. These folks have a stroke program. These folks have a chest pain program. So clearly we want to drive this. This is a high value for the patient, for the practitioner, for the hospital, for the community. And this is the first time we've ever had an opportunity to look at data this big. And we're going to look at this. We're going to trend it out over time. How are we doing? Well, I don't know what's happening in August and September. Something's going on. Is it RSV? Is it flu? I don't know. Let's take a look. Let's find out. Let's do something about it. Talking to this group, they said, we are not adequately resourced. We don't have enough resources to get this job done, to get them seen within 20, to get to the first vital sign within 15. And then there's other things also in this portal that there's other trees in this portal that I'm not sharing with you. But one that they were very interested in is these seconds to minutes emergencies looked at by census. And so, Jonathan and D2I did their magic. We created an algorithm for census and applying this. And what should you be staffing for? Probably medium census, right? Well, medium census for all these things coming to the door, and they're pretty in the red here. Low census, this is no surprise. The bar here for low, then medium and high gets higher and higher, but they should, all should be moved to the left. And we know that this group is going to go up. Talk with administration. We happen to personally know the administration. We're very interested in seeing this data, and perhaps this can drive improved resources or improved logistics to get workflow and get these patients seen faster. The same issue here with door to vital signs and seconds to minutes emergency. I'm not going to spend any more time on that. This one really interesting. When when I'm a medical directors academy, I'm saying if there's one group of people, one group of patients you want to grab a hold of, bring back to your monthly department meetings because there's so much to learn from, it's return visits that get in 72 hours to get admitted. There's almost always something where you can learn. And it's great quality improvement. So you hear there's a return visit here or there. You tell your admin to go get some return visits. Okay, here we've got them all. This is return visits like you've never seen them before. So these are bounce backs, and in general, you look at the literature, you look at Benchmark Alliance, talk to your colleagues. 3%, 4%, 5%, it's pretty typical for an emergency department to have a bounce back. And then for those that get admitted is around 1. I showed this slide for a couple of reasons. And I just got another reason a couple of minutes ago. Above the waterline there is malpractice cases. Below the waterline is the enormity of medical errors from which medical malpractice comes from. And I just love the graphic because of how important it is to recognize malpractice is important to look at. But medical errors is really the critical issue here. And above the line there, you've got a lot of costs. I just changed this. What time is it? 10:36. I just changed this 40 minutes ago because Aon has published some new benchmarks. This projected loss rate per patient. We are in an insurance crisis right now, by the way. The costs are going through the roof. This is very painful for hospitals and physician groups. With leadership on this call, you probably know this. This just changed from $6.80 to $10.70 per visit. This just changed from, I think it was 10,000 per emergency physician. If you employ your emergency physician, it just changed to 16,200. That's a crisis. It's always time to pay attention to risk and safety. But if you want to put a value on it, right, the value just went through the roof. We're in a crisis. Down below the waterline here, errors leading cause of death. One of the leading causes of death in the United States, people die per 100,000. I put this back in here again because because this is what's driving these return visits. When I say it's over 3%, remember, point is that includes spinal epidural abscess coming back. That includes dissection coming back. That includes pulmonary embolism coming back. So 3 to 5% is really nothing to be proud of. It's just the current bounce back rate. We need to make that go down. And how do we do that? Well, again, transformational, working with D2I, get every single return visit. So let me orient you here, and I've never seen this before in the world of emergency medicine. I've never done it before. If you work with some of the big emergency medicine groups, I know a couple of you are on, you may be doing this now, but looking at return visits by clinical entity and for all the patients. And so what we got here is the qualifying discharge, those returning within 72, the percent with the same diagnosis, with a different diagnosis, who got admitted and what percent. So I want to orient you to this, but then I want to jump to the bottom of this particular report in the portal, down to the bottom where for this 4 EDs for this organization, they're 6.4. And admits are at 1.2. So it's in the yellow because the returns are over 5 and the admits are over 1. But if you just got this number as a leader at ED 1, 2, 3, 4, what would you do with this? Not much. Don't know. Not too high. It's a little higher maybe than national benchmarks, but I don't know. I'm not sure. But what this report gives you the opportunity to do is find the outliers by clinical entity and by emergency practitioner. So let's take a look. CHF, there were 13, 2 came back, 15, 4, 7.7, not that many patients, but it's a pretty high number. Diabetes came back, 21.5, 23.8, 9.5 got admitted. Well, you're in a portal. This is Q3. I wonder what that looks like for Q2. Well, Q2's got an issue with CHF and diabetes, and there's 20 of them, and 12 came back, 60%. I've got 22 diabetes, 12 came back. Now, this is something. Here, take the cases of CHF, take the cases of diabetes, and look at them, because there are going to be similarities between them. Diabetes didn't get their medications refilled. CHF, wrong dose of diuretic, didn't have a diuretic. Didn't get follow up. You find the outliers, you do something about it. Is it valuable? Oh my gosh. Valuable for your patient, valuable for the practitioner, valuable for the hospitals that we work with. They're in a readmission reduction program, and it's a big deal. So take that report and look at acute MI, COPD, heart failure, pneumonia, and determine, have we got outliers? If we've got outliers, let's do something about it, and let's make that go away. So it's transformational because it's really the first time with that to my knowledge, that we're able to do something like this, and it's special. I don't know, it's special, and the numbers get really big really fast. Same thing with the practitioners. Okay, we got outliers. Well, we made the yellow 5 to 10. That might be a little bit high. I might want to change that. I might want maybe up to 5 is green and then 5 to 7, because at 8.2, there's a lot of people returning. And, we learn as we go here. We don't know the answer because this is the first of its kind you're looking at right here. Here's an 8.2, here's a 6.7. And jump down to the bottom of this presentation, and there is, somebody saw 290, 30 came back, that's 10.6. This is something we want to do something about. One thing is we want to share this data with the group. We want to be transparent. We've just never had this before. Now that we've got it, get it out there. Do we want our patients returning in 72 hours? No, because as we look at those cases, we know that there's often something wrong. Then we've got our top 20, and we can drill down on the top 20. And again, this is educational, right? This is how we change things. We look at the data, we drive meaningful change, and you keep looking at it month after month, and everybody's on board. It changes the culture. It creates a culture of risk and safety with not just the practitioners, not just the nurses, but everybody, and for the whole hospital. Maybe even for the first time, have the only department in your hospital that's really got an incredibly power risk and safety program. Maybe it changed the whole hospital. Maybe it impacts the community. Um, so, but in addition, you may have folks who just, don't seem to be making the grade. You got folks who maybe, when we presented this to these folks, they said, yes, that makes sense on these practitioners. We're seeing somebody. We really haven't had the data behind, any kind of meaningful action where, they need to either get better or they need to move on. And if you got some people falling out, if they fall out month after month, it's somebody you should be having a discussion with, but giving them the opportunity through education to do better. Also, 72-hour trend, how are we doing month by month? Well, wow, something happened in June and July and August and September. I wonder what that was. You're in a portal. Drill down to ED1. Is it ED1? Yeah. Is it ED2? Yeah. Is it 3? Is it 4? Yeah, it's all of them. And so it's not a department issue. It's probably an environmental issue. It looks a little too early for RSV. Was it a surge in COVID? It gives us an opportunity to do things that we haven't done before. So I'll show you one more tree, and then I'll get back to the forest, and we'll take a quick look at the key performance metrics. I'll have a little more discussion, and then we can open up for questions that you might have. But we want to look at left without being seen, which you probably do already. But we wanted to look at them. Who had vital signs, who didn't? Are there a lot of them? Don't know. Never looked at it before. And I was looking for a nice, cool image, to put with this subtitle slide, and I really couldn't find one. How do you find a picture of somebody leaving without treatment? But I found this, and I'm in San Diego, and I thought, oh, I'll put this up there. Okay, this is 2019, 2020, and 2.6% of all discharges left without being seen. I'm sorry, this left against medical advice. That's a lot. That's a lot of patients. So it's an important group. If they leave without being seen, they're leaving against medical advice. It's a risk group. It's a risk group. Do they self triage because they're urgent care kind of patients, because they're fast track kind of patients? No. You have all looked at left without being seen, and it's across the board. There's people with chest pain, abdominal pain, scrotal pain. They're getting out of there because things are taking too long. And so here's the whole organization, and the numbers don't look good. 6.6, 7.4, 5.1. We're working with some, as Scott said, it's disparate groups like the Sullivan Group coming together with D2I to get this data. We're coming together with organizations that look at something like this and they say, we've got $4 million we can keep at this organization by changing those numbers. I think this group can probably change the numbers, but we know people on the ground who can take your 6.6 or 7.4 and they can turn it into 1.2. And they can show you that that means a whole lot of money for the organization. Is it worth it? Yeah, it's worth it. Then we're looking at the vital signs that are going home, that the patients are going home without having an opportunity even to get vital signs taken. And what's going on in that emergency department? So, you got your portal. Here we should look and see, is this ED1, ED2, ED3, ED4? Well, here's ED1. They're better than the organization, but the numbers are still a little bit high and left without being seen. And a lot of people are leaving even without vital signs. So there's a pretty significant risk right there. Is it ED2? No, they seem to be kind of right on with their LWBS numbers, but 34%, 30%, 22 for people leaving without vital signs, probably something we want to get a look at. The issue is really here at ED3, which is where this organization needs to get a focus. All right. Well, there's other things in there. There's other opportunities in there, because anything I just showed you, you can take the data, you can download it, you can filter it, you can run it any which way that you want. And more opportunities that we continue to work on, because when you see the opportunity afforded by having all this data, your mind just spins at the opportunities. At ASAP Scientific Assembly, we had 3 university residency organizations come up to us and say, wow, there's research waiting to happen, and things that we can get out to the emergency medicine community as a whole, and we can learn a lot with this programming. So back to your key performance metrics. Now they'll make sense. You've got to have normal vital signs at discharge, and there's way more in this portal than this, but you can only put so much into KPIs. Current month was 10.3. That trend is going up. But we wanted to know that doc got the last look at the vital signs, 6.5. Nurses took a set afterwards, 3.8, and that's going up. And we pulled out the most dangerous of them all, We pulled out the abnormal pulse of 3.2, and that's going up. We've got return visits within 72, green and going down. We've got door to bed, all red. We have to do something about that. And we call out chest pain, we call out stroke because you may well have programs around those specifically, and you may have hospital organizational, you may have national quality metrics that that you're dealing with there. And so those numbers are just too long. You've got your seconds, your door to vitals, you got your return visits with any complaint, your return visits that get admitted. And immediately below that is all four of these emergency departments. Could be 2, 4, 6, 8, 10, depending on your organization. And you can see we've got, at a glance, we've got some things we need to work on, change. We've got some training we need to do, some education that we need to do, and we need to monitor these things over time. And then the ability to look at the KPIs by ED1, ED2, ED3, ED4. Just, wonderful opportunity here with in this partnership with D2I. So the roadmap ahead, as I mentioned, we're changing things as we go. We're adding on. There's plenty there. This is live. This is working. We are meeting. We are becoming proactive to try and make some changes in the organizations that we're working with. But we're adding more, as we speak. First half of 2024. We want to jump into the unstructured text with the opportunities that NLP and the large language models offer us. And so we'll be working on that. That is very dynamic. It is very cool. And we're just we're chomping at the bit to get that development off the ground and up to speed. Second half of 2024, we'll then have an opportunity with our early adopters to be able to say, here's what we did to drive that change. The abnormal pulses at 3.2% is now under 0.5. Our CHFs have dropped from 50% returns to less than 10%. We need to drive change in those areas, and we'll be able to demonstrate that. And then we've been asked already, can we do this for hospital medicine? Can we do this for primary care? Can we do this for others? And as we develop new partners in this area, of course we can push and develop into those areas. So thanks for taking the time. I hope that you found this as meaningful as we do. I do believe it's a new day. I've been doing this for 30 years. It's the first time I've ever had access to something like this, and feel like it's a game changer. So Scott, I'm going to turn it back to you, and then I'll remain here for any questions that may have come in the chat or that you may have. So back to you, Scott.
Well, thanks, Dan. That's awesome. Every time I hear you talk about this stuff, it gets me more excited. So this, you probably already looked through this already and seen the numbers that you want to see. What I want to draw your attention to is the fact that at the very bottom, off of the subscription fees, we are running a program through the end of 2023, or actually for the next 5 early adopters, to get a 50% off the subscription fees if you're in before the end of the year or before we get to the 5th one. So there is a process that we go through to acquire the data. I know we have some D2I clients on the call right now. We already have your data, so we'd be able to forego the data acquisition startup fees. But the dashboard startup fees would still apply. And again, the subscription fees that are coming in at 68 cents would be knocked down to 34 cents per visit for the early adopters that get in before the end of the year for the risk dashboard. So if you have any questions, put them in chat. But I hope you all have enjoyed this, and we'd love to get again your feedback both through chat right now, or certainly reach out to us separately, and we can schedule additional follow-up or conversations.
Thank you, Scott. Thank you, Dan. We actually do have some questions in the chat. Scott, this one would be directed to you. It's, what is the time to set up data feeds with a new hospital site? So if you could speak to the process that D2I goes through with the hospital site on getting the data and the scripts.
If it's an existing a D2I client, we have the data already, and we can we can start working right away. For a new health system or a client, the rate limiting factor is the speed in which we can get the IT department to engage. We provide the IT department the data extract scripts, so they don't have to develop interfaces or programs to acquire the data. We provide the scripts that they implement and run. And the time frame for that to occur in their space is on their side of the fence. Once we have the data on our side of the fence, we're putting these dashboards out in about 3 to 5 weeks. And a lot of it has to do with, timing of being able to get people to validate data and into meetings, availability. Hopefully that answers the question.
Yep. An extension to that, what is the process for validating and normalizing the data? So you'd kind of so maybe keep going here, Scott.
Yeah, no, so the normalization is, that's really one of our IP that D2I brings to the table is that whole normalization across Epic, Cerner, and Meditech. That's already baked into the products and services that we do. It just gets extended to this RSQ, or the risk dashboard. As far as validation for a new client, and I think Dan spoke to this a bit with regards to the existing the sites that we've gone through, is we go through a pretty extensive validation because sometimes the numbers are a little bit hard to believe. But the process is we look at the data we're acquiring from the HR, and we have somebody working with us that's looking at the actual patient encounter on Epic or Cerner, and we're reading back and forth between what we have and what they're seeing on the screen to validate that we have exactly what's in their environment.
Great. And I think, I don't know if Scott, if you touched on this and maybe just restate, like what, in your experience, what's the typical time range of time for hospital ITs to implement your data extraction scripts?
It's really spanned the whole spectrum. We've had our data extracts scripts provided to sites, and within a week we're getting data. It depends on their process and methods. But it can be very short, and we've had situations where it's been a couple to 3 or 4 months.
Yeah.
So it really runs the whole gamut. And I wish we were in control of it, but it's not. We've got to work within the process that they give us.
Great.
We've been involved with this and other products where we've run into a wall on the IT side. And you folks who are on this call know other things that other areas where we've needed IT support, and it's really tough. But D2I has been doing this with clients for the last 10 years, and somehow seem to have cracked the code on getting people to do things that they want them to do, which is a good reason to be with them. You can't do it alone, and D2I's got some magic, and it could be a week, as Scott has said, could be some months, but but they're getting them. They've got clients who can attest to the fact.
We've had a lot. We've had an incredible amount of success, and a lot of it has to do with the fact that we provide them the scripts that are necessary to implement to pull the data out, and the level of effort. Many don't believe is going in and admit to it on the backside. It's anywhere between 6 and 12 hours. And a good portion of that is related to getting historical data that we like to have in order to be able to do the trending as early as possible. So if we can get 12 to 15 months, we can do a lot of trending right away. So you don't have to wait to generate enough data to have 6 or 8 months of trending.
Well, great. Well, again, thank you for everyone joining today. I think that's the end of our questions. Great job, Dan. Great job, Scott. We will send out the recording to those that registered and attended. And I know that some have requested the slides, and I'll send those out individually to those groups that have requested the slides. But really appreciate everyone's time. And
I can make one more comment, because I know that
Sure.
the question's coming from somebody that we do have sites that are on our service. So we already have the data for I guess 8 or so of your sites. So I just wanted to mention that because I see who the questions come from.
Yep, great. Excellent. Well, thank you so much, Dan, Scott. Appreciate your time and great message again. So
yeah,
talk to everyone soon.
Thank you.
Bye now.
You see Stephanie wants the slides too? I saw your message, Stephanie.